Hey guys, welcome back to the Dr. Cliff Show. I'm Cliff Olson, Doctor of Audiology and founder of Applied Hearing Solutions in Phoenix, Arizona. And I am joined today with two very special guests because we are going to be talking about tinnitus and specifically about the Lenire Tinnitus treatment device. So, join me in welcoming Dr. Emily McMahon and Dr. Jason Leyendecker. Thanks for coming on the show, guys.
Thank you for having us.
Yeah, it's a pleasure to be here.
Awesome. So there's been a lot of talk lately about not just tinnitus, but really this new device that is got FDA approval here in the United States. It's been around for a little while over in Europe and places like that, but it's something that's very new here. And so we wanted to do a sit-down talk with some people who are actually using that particular device in their clinic, but not just people who are using only that device, but are incorporating as part of a more, robust tinnitus treatment process. And so what I'd like to start off with is you guys introducing yourself and your clinic and really what your expertise and background is with tinnitus. And Dr. McMahon, we'll start with you.
Sure. So I'm Dr. Emily McMahon, and I am an audiologist predominantly in Anchorage, Alaska, but I also see patients all across the western United States. I have been practicing for the last 10 years. All of that focus has been predominantly in tinnitus with different tinnitus work, and getting to be a Lenire provider has been exciting, but it certainly was just adding into my toolkit throughout the years, involving different counseling aspects, different tinnitus treatment processes, and then sometimes involving amplification, sometimes not involving amplification. So having a new tool to add in has been a helpful addition into our practice.
Very cool, very cool. How about you, Dr. Leyendecker?
I'm Dr. Jason Leyendecker. I'm an audiologist as well, practicing out of Minnesota in the Minneapolis area. I went through a tinnitus training back in 2011, specifically the tinnitus retraining therapy approach, and ever since then have primarily been focused on seeing tinnitus patients as well, and have been involved with several subject matter expert opinions on different approaches to tinnitus with the American Academy of Audiology or American Board of Audiology, as well as other venues as well.
Very cool. So you guys have been involved with tinnitus long enough to be considered experts essentially in our field with tinnitus treatment. So you guys were actually identified by this company Neuromod to come out to, I believe it was Dublin, Ireland, am I correct with that?
Yep.
To kind of show you what they have had, or what they've been working on essentially. They've had some pretty impressive clinical trials with their Lenire Tinnitus treatment device. Can you guys explain really what that device is for someone who might be hearing of it for the first time right now?
So it's a device that's using a term called bimodal neuromodulation. So bimodal meaning two pieces. The first piece is an auditory stimulation, so there's a pair of over-the-ear headphones, and then the second piece is a tongue tip stimulator. So think very light vibrations or stimulations to the tongue, and those are used in sync with each other. So they have different levels of intensity, and that modulates throughout the process. We're working on redirecting the brain's pathway in how the patient's perception of their tinnitus is shifting and changing. How that outcome is quite varied on how their brain kind of perceives that outcome and what those changes look like. It is the first device of this type. It is the first bimodal neuromodulation device in our field, but especially within the tinnitus field. And something else that was, exciting to get to be a part of it was they received what was called a de novo grant, and that to be accompanied along with the FDA is, think of it like a double stamp of approval almost. It's basically the FDA saying that we are deeming this to be as effective as the studies are showing it to be. And I think, as a provider, it's always a little apprehensive to be involved in anything new. Our patients have a lot of trust in our abilities to make appropriate decisions for their healthcare and help to guide them in making those good choices. And so I think a little cautiously optimistic early on, but now that we're about 7 months into it, it has in general been a really nice addition into our practices.
So you bring up an interesting point. So there have been other types of tinnitus treatment devices that were out there, not necessarily using bimodal neuromodulation, but we've seen things come and go, flash in the pan. People get really excited. They're like, we're going to start incorporating this in our clinic, and it just fizzles out, most likely because either it's just not effective or the implementation of it is not really done well. So how is this really, now that you guys have gone out there and you've seen all the data that they have as a company so far, it's been around, they have some probably real world, data on that as well, but what was your guys' perception of this particular device when they first announced it?
I was really excited about it. To your point about doing something with research and then trying to implement it, there is a difference between doing the research and using that data versus getting actual real clinical data and using that in your practice, and how can we implement that information. I think being part of this group of providers that have started with it, really, we're still defining some of those things, but it's been going very well. It is exciting to have something else that is not a hearing aid related tool for some of our patients that aren't necessarily ready for that. And it just also, it creates a little bit more excitement around the fact that there's still hope. And when this product has been researched and published for a while before we even had a chance to get it, it gave us a lot of patients right up front that were pretty anxious about it and excited about it, and that created some issues with regards to setting expectations with them.
Yeah, I have to say I might be a little guilty on expectations of that. So I think I had published a video. This video might have been published right when you guys were going out there. And I may have used the word cure for tinnitus in the thumbnail of that, whatever, okay? Yep. Don't judge me. So, but I just want people to know that, like, there's things happening, like there's things going on. I was very excited by the clinical trial data. When you look at the Tent 1A, the Tent 2A, and I think they've even had a third one now. Yep. And when you look at the FDA, when they go through their de novo approval process, I mean, it's pretty stringent. Like it's strict. Like, you have to go through and show that this would be an effective means of treatment to even obtain that. So what did you guys think about, like, when you went out there, what were their talking points? What was Neuromod's talking points about their device when you went out to Dublin?
There was a lot that we covered in Dublin. I feel like at the end we got to go over, what was it, for 5 days of learning. It was pretty 5 intense days of sitting, in a classroom, so to say, of a lot of information. So we got to speak to the scientists that are behind it. We got to speak to the creator of the device. We got to speak to kind of the clinical side of the team. And then the other portion of that is we actually got permission to get to go into clinics and witness the device in real life. So, from a provider perspective, it's one thing to sit and attend a training. It's another thing to see a device in the wild, so to say. Yeah. And, so we got to see that. And then in addition, we got to be then with our counterparts to say, okay, what were your thoughts on that? How would we implement this, and be able to do that troubleshooting back across? Because the 15 of us that were chosen for that, one was an ENT, one was a nurse practitioner, and then we had a 4th-year audiology resident. So out of all of us that were practicing, pretty spread across the country nicely, which is nice because regionally we get to learn what was different, troubleshooting off of each other, everybody coming up with how are we going to implement this in a way that what not everyone knows is that as those early on providers, we then had obligations to turn back in so that we could kind of exit that validation phase. So those first 6 months post-approval is we all had to collect data and gather that data and then report declassified patient information. So none of that information is privatized, but we have to report all of that back so that we can continue those studies and data from not the clean clinical trials, but the messy in real life patients that are not always as clean cut as the trial patients are.
Right. Now, I know a lot of you guys who actually went out there to do it, and a lot of you personally who went out there to do it. And I know that you guys are not just accepting of every new thing that comes out. So, I mean, was there a level of skepticism in you when you went out there?
I would say cautiously optimistic is the term I like to use, because you want to help your patients, and sometimes the hearing aid route or counseling route isn't the route that they want, and having that extra tool in the toolbox is really a nice thing to have. So you go out there motivated to make sure that it can work as well. And when we have experts from around the country all working together to make sure that we're all on the same page of how it should work, it made it a lot easier for us to to make sure when we get back to our clinics, we kind of have a game plan of what to do with it.
Yeah, you know, I spend more of my time working with hearing aid manufacturers and reviewing their products and using their products to treat hearing loss in my clinic. The thing that drives me crazy is when you get someone who really doesn't know the ins and outs of the devices and how they're functioning, and you ask them questions and they give you answers that is like, okay, that's clearly just like a rote, you know, memorize, this is what we say when someone asks us this type of question. Did you guys get a feeling like the people that you were interacting with over there like really knew their stuff?
Yes.
Yeah.
I don't know who put that team together in the global sense of the word, but they did their homework on the front end and on the back end of that. The team is small and mighty, but they are very well rounded. They are very knowledgeable. If we reach out and they don't have the answer, they know exactly to whom to direct us to get the correct answer. And that comes from a research side of it, or an in the field side of it, or potentially a question ordering side. They've really done a good job of clinical support for us.
Yeah, I'd use the word responsible.
Yes.
They're trying to make sure that this is a success and not just throw it out there and see what sticks. They wanted to make sure that this has enough weight behind it that it can grow with actually having effective results all the way through.
Very cool. So now that you've gone through that training with them, let's talk about the validation period, because I'm not sure a lot of people understand really what that means. Like they see FDA approval, they're like, okay, great, now like it's in the market, ready to go. And I think that's true to an extent, but they really just launched it with was it 15 clinics across the United States? But can you guys explain like what that process was?
So there were actually I think 11 clinics that ended up launching, because some of us are doubled up.
Okay.
So 11 different clinics that had access to ordering the device in a large country like ours. So that, of course, is a little bit of high demand and not a lot of us, which created certainly a little bit of a frenzy early on. On our end of things, prior to even receiving FDA approval, we had all agreed that we would make sure that our data collection points were appropriate, that we would be following up with making sure that we were doing our due diligence of gathering appropriate that we were gathering appropriate subjective and post fitting and measurements and things like that. And then we have to do data reporting each month on what do our consultation looks like, how many things is this doing, what is our moving forward, what is our help rate, are these patients finding clinical significance, are they not finding clinical significance? In the event that we were to have an adverse fitting reaction, then we have an obligation of needing to report that. So it's not that it's created a lot of work. These are things that, to be fair, we've already been collecting this to begin with, but it is an additional step to make sure you go in, fill out your reports, turn all of that data in, because we do have that back end requirement of being one of the first providers with access to something that the company then has a due diligence to turn back in to make sure that they can show not only did we have the clinical trials to support this information, but then when we had the data in the real life patient hands and in real clinic hands, that it also supported the information that we were providing. And so being some of those clinics, those are some of the things that we have been asked to support and to be able to provide back that information on. And so we have technically left that post 6 month time frame. That was ending at the end of October, was the end of our 6 months. And we've all turned in our information. But to be fair, that's not been published information yet, because it does take time to get that. So it's all been collected, it's all been turned back and reported, and that is all in process at this point.
Gotcha. So I guess I would ask then, like, just, you know, anecdotally from your end, right, with the data that you guys collected, would you say that, because their clinical trial data was like, oh my gosh, I don't think there's any treatment in the entire world for any condition that has like a success rate like this, but also the long-lasting effectiveness of that treatment. Were you guys seeing data inside of your clinic that kind of mirrored what they found in their clinical trials?
Yeah, and I would add that the data that they were collecting was looking for minimum quality of life improvement. You know, we're looking for maximum in the clinic. So, but I would say definitely anecdotally up front, we were seeing very similar results, if not better in some situations, of having better reactions when we communicate with the patient more. You know, not just having them come in, get fit, and then see them in 12 weeks, you know, having follow-up visits within. I was definitely seeing really similar results, if not a little bit better.
I would agree. We've well met the clinical trial numbers, and I would agree we've come in slightly slightly better than what we were expected. But I do think that a lot of that comes in the follow-up care and having an established protocol entering this. And then I know, Jason and I have spoken amongst the providers is not every patient that wants this device is a good candidate for this device. And that can be part of the hardest portion of it is they see it, they want it. There was a lot of buzz that they may or may not have heard about it. And so they thought this is what they needed. And then they might come into our office and it might not be the device right now. Maybe we need them to do some, we'll call it homework, so to say. And it doesn't mean that maybe in the future they couldn't have it, or maybe even in the near future. But it's not always the right time for every patient at that. And that can be a really hard aspect. But I think having the appropriate parameters is also why many of us are finding that we very comfortably stayed within the clinical data, if not exceeded, was just knowing really good boundaries of this makes up a good patient to be a good candidate for criteria for moving forward versus probably not going to be the best device for this particular patient, and identifying that before we get them into a device that is potentially setting them up for a disappointing outcome.
Right. I'd add in there, I've talked a lot about having a non-hearing aid related product. We still fit a lot of hearing aids, and that is still a heavy recommendation for the situation when they have a significant hearing loss. So I won't say that is not still a good fit. And on top of that, counseling. Now, some of our patients come in with desperation instead of motivation. And there is a big difference there in trying to identify that and making sure that we're getting the right person starting the treatment in the right mindset with the appropriate expectations has probably been the biggest challenge right off the bat.
So I think that's interesting. So there's different phases of this, right? And you had just mentioned, so I think throughout history of hearing aids, when the data started coming out that a lot of individuals get, suppression or reduction of annoyance level of their tinnitus using hearing aids, what is that progression that you would typically take someone through? Because there might be someone watching right now who's thinking, oh my gosh, like this is the thing for me, but they haven't gone through any other evaluation, they haven't attempted any other treatments, and we're really looking at someone with more of like a moderately bothersome to a severe or catastrophic level of bother with their tinnitus. So what is that progression that someone would typically go through?
Well, in our office, we're going to do a full assessment. And in that assessment, we want to make sure that we're addressing all of the auditory side of things, including as much information as we can get. We want to know sensitivity levels for sure, both the softest and the loudest sounds that they can tolerate, to make sure that we're sitting within the right parameters for the equipment and or addressing hyperacusis first if they have hyperacusis on top of tinnitus.
Help us understand, what is hyperacusis?
Hyperacusis is sensitivity to loud sounds, often in a scenario where they actually hurt, where they don't necessarily bother other people.
And then we also have the case potentially of misophonia in there, and then how that differs from tinnitus and from hyperacusis.
So misophonia is a hatred to specific sound. So the emotional reaction for hyperacusis is more fight or flight, whereas with misophonia it's more anger, frustration, and rage towards those specific sounds like lip smacking, gum chewing,
chomping,
repetitive tapping.
I think my wife might have that when
you?
I'm eating. Yeah.
Oh yeah, the more time you spend working with these patients, the more you start to develop some of these things yourself. Yeah,
you're like, I hate that too.
Yeah.
So you have to be able to differentiate okay, what is actually the problem that they are having. You go through this evaluation, and then let's say someone is more in that more mild level of tinnitus, annoyance, so to speak. Where do you typically go from that? I mean, it could just be counseling in and of itself.
Sometimes counseling is all that they really truly need.
Yep.
They may have come in with a lot of misinformation, or they may come in with little to no information, or just what they've Googled, which often is full of misinformation. And so sometimes just appropriate counseling and then knowing that they can reach back out to you, sometimes that's powerful enough. And then I would agree, looking back at that, it's sometimes they do just need amplification, and we might not even do amplification plus in addition sounds. It might just be amplification plus counseling.
Yeah.
Counseling is an incredible tool when it comes to tinnitus, and to be fair is one of the biggest differentiations that's going to come from a practice that does tinnitus like Jason and I do versus a practice that does hearing aids and throws sound into them and calls it tinnitus. Is that counseling, that physiological understanding, that ability to work with those patients and work through it is really going to come down to counseling and understanding, why am I using sound? What types of sound am I using? How am I implementing those sounds? It's not just turn it on, push it on, throw it in, run away, which is so often what is utilized in other areas. But counseling for those patients you're talking about there is sometimes just the number one step, and then number two often being amplification.
For sure. I know that we've had patients come into my clinic where they just need to be told like what it is, what's potentially causing it, and once they're like, oh, like this isn't going to kill me, like
then
I now understand that there's some other coping things that I can do, like I personally run a fan at night when I go to sleep, so my tinnitus doesn't keep me awake, you know, like something simple like that. That doesn't necessarily mean that you have to go through extreme measures from a treatment standpoint with it. But then you get these other individuals who, you know, they may have gone through, let's just say this, they may have gone to one of these clinics that are a hearing aid clinic. Let's not, I mean, it is what it is. They're a hearing aid clinic that they dabble in tinnitus. Right, we're like, they're hoping that if you get fit with hearing aids, that the tinnitus, you know, is suppressed to some degree, and maybe you get some residual inhibition. Maybe you can use a masker as a tool. I know that your stance on masking is like, masking is not what?
Tinnitus management.
Yeah, it's a swear word in my world.
That's right.
Yeah.
We will agree on that one very heavily because.
But I have to say that when you speak with certain audiologists or individuals who, you know, even specialize in tinnitus to some degree, like the tinnitus masker is their go-to when it comes to treating the tinnitus. But that's really not what we're talking about here. We're not talking about using like this Lenire device as a masking tool. In fact, it goes beyond just the ears, and we're really focused on the brain, if I'm understanding this correctly, right?
Correct. Yeah, and the reaction. It's all reaction. How the brain is reacting is also subconscious. So you can't just control it by saying, oh, this is a happy tinnitus sound. You have to go through the process, and if they're not educated well on what that process is supposed to be like, then when you put that tinnitus masker on, it likely could actually cause things to get worse.
Yep.
Yeah, that's interesting. Way to look at it. I mean, we always think that we're doing the right thing because they have tinnitus management tools inside of the hearing aid software. That's like, oh, well, this is the way that I just address tinnitus. And that it almost sounds like it could be backfiring as well.
It can, and even more so than just backfiring is, unfortunately, what will happen is they then have a negative connotation towards amplification. And it wasn't necessarily the amplification, but potentially the sounds that were added in through the amplification. So then they end up in an office like ours, and we have to unwork that process and rework through that fear, because they still probably need amplification. And then you have to reintegrate that. And so, you know, that's where masking inappropriately, and when not used in a safe and appropriate manner, really can be counterintuitive and can be harmful to our patients.
So it really sounds like, from I know both of you really well in how you go about things, you have to have the evaluation done first. Like doing any kind of tinnitus treatment without a full-on evaluation of their auditory system, full case history to pull stuff out of them that they didn't even know was potentially leading to some of the tinnitus is very important.
Absolutely.
Now, what when you think of like order of operations in that sense, like if they have a hearing loss and they have a significant amount of tinnitus, I mean, chicken and like which one do we go to first? Do we go to the counseling, hearing aids, and then potentially Lenire device? Do we like you skip over hearing aids initially, go to Lenire first? Like, does it depend?
That is the answer. Depends.
Yeah. I was gonna say, I don't know that we can give one answer because it is going to depend. Sometimes they are willing and will go from hearing and go that direction and then allow us to go tinnitus and go that direction. Sometimes they're unwilling to go that, and we're going to start with tinnitus and then we're going to build into hearing, and sometimes it just goes a little haywire and you're like, let's try to make the best of this as we can, and what are we willing to do today that we can be safe and feel comfortable and follow through with it. So I don't know that I can safely answer that as clearly as or as cleanly as you would like, just because the patients that we're talking about and that we both spend such a heavily time working with are pretty complex, and they have very high needs, and their needs and their complexities have to be first. But then we also have a due diligence of how do we work through that with them in a way that we're also serving their needs, but also their safety as well. So there is a little bit more give and take than when we're talking about just like, hey, you have hearing loss and we're going to fix your hearing loss, and here's how we fix it. There's a whole different side of what we're up to over here.
It's
and
kind of funny because, like, even with treating hearing loss, there are times where I'm like, oh, this is what I need to do to treat you, and then we start that process of like, oh, I was wrong, based on your auditory perception, based on a lot of variables that might have gone uncovered or that didn't even crop up until you started doing the treatment. So I imagine similar things happen, obviously,
it's
probably
always a surprise.
A larger extent, I would argue, with tinnitus.
There's a saying called that if you've seen one tinnitus patient, you've seen one tinnitus patient.
Only one.
Every patient is unique, and their journey is going to be very unique to them. So that's where the expertise in tinnitus really plays a role, is you got to really figure out how to design the treatment journey for that patient individually.
And right when you think you've solved it, the next 10 will prove you wrong, just to make sure you are knocked down.
Yep.
So it's kind of funny because clearly there's a very individualized aspect of tinnitus treatment. But there also has to be certain processes that you follow to make sure that things aren't missed, that you're doing things in a comprehensive way. You can't just be shooting from the hip on every tinnitus patient that you're working with. So I'm kind of interested in how you guys had your systems and processes in place for how to optimally treat your patients before Lenire really came on the scene. And so how difficult was it to start incorporating something that was different than your normal process?
So for me, I don't think that the incorporation of it was difficult, because it was another, here's what our different options are, here's how this method works, here's how this method works, here's how this method works, and kind of what do you feel after giving education and talking about what our different, kind of treatment plans look like, what did the patient feel that they could be empowered for when appropriate? Obviously, we're talking that they were appropriate for these, and those would have been the options that I gave them, and then empowering them to make the choice that they felt is most clinically appropriate for them, within the parameters that I had already cleared them for, so to say. Because there's a lot of back-end work that we need from our patients. They have to be consistent with whatever it is that we're asking of them, whether we're going a TRT, or a tinnitus retraining route, whether we're going like a progressive tinnitus route, whether we're doing the Lenire route. We are asking of things from them. Consistency, follow through, also coming back to us. Like, there is a give and a take. We can give them excellent information, but if all they do is get the information in our office and then never do anything with it when they go home, we're never going to see progress being made. And so, when I'm looking at from there is, we've gone through an extensive case history. We've gone through our consult. We've now kind of thrown all the cards out on the table, so to say, and then here's what the options are. Where do you feel you will be most successful in? And then let's go with that. Mm-hmm. Because I don't always necessarily know, and I could pick the wrong answer because I am not you, and I don't know what makes you most comfortable or what you feel most comfortable with, but I can give you that information, and I can give you the appropriate information and then help support you in following those aspects through.
Have you found it to be difficult to incorporate Lenire?
I think the challenges really came with the influx of patients.
Oh, yeah.
The phone never stopped ringing.
Ever.
We started creating a little bit more on the educational seminar side, so that way those who just wanted information didn't need to sit through a full assessment. Those who wanted to come in and get the assessment after, it made it a lot easier for them to get in because they already had that part of the test or the appointment, so we could actually just review shortly and not have to have a 2.5-hour appointment like we normally would. So that was one of our biggest challenges, and when we incorporate it into our practice with that, you really do have to still stick to your protocol in how you treat patients, because if you try to modify it just to get more patients in, you're likely going to set somebody
Fall
up
apart.
for failure.
Yeah. So let's talk about, I'm sure that you guys have a patient on the top of your mind that you've used the Lenire tinnitus treatment device on that actually went really well. So maybe even a case you're like, I don't know if I could have treated this patient successfully without using this device. Can you guys think of a particular patient that you had?
So I have a patient who I had done other tinnitus work with this patient. She was not new to my clinic. We'd worked together for I think almost 3 years, and she was doing okay. We had gone from a not great place to an okay place. She had recently undergone some updated cancer treatments, and her tinnitus was in a really unmanageable position following her most recent radiation. And so we were almost back to square one, which for her was very frustrating, understandably so, because she had worked so hard to get to a more manageable place. But the tips and tricks that had been working for her were just not working at this point. She had previously received significant relief from using her amplification, and we were not there anymore, and it was like she was a brand new patient to me. And so this was a patient with long-standing history I had seen kind of ride different waves of her tinnitus journey with, and she went from scoring in a catastrophic range. We ended up going about 18 weeks with her, so we did go beyond the 12 weeks. We did an additional 6 weeks of time frame, and she's in like a maintenance program at this point, but we got her down into the slight or no handicap level of scoring with her tinnitus. Now, that is a super responder. That is also not realistic to tell every patient that that's where their scores are going to be, nor am I going to be making that, but it can happen, and I've got several patients that I can think of that they've been these kind of super responders when we just gave their brain enough of a different type of stimuli. She'd done TRT before, she'd done amplification appropriately, and we just, like I said, after this most recent round of oncology and radiation, what had worked for her before wasn't working. When she started with Lenire, you just watched her put it on and put it in, and this entire calm came over her whole body. And it was one of those ones where you don't want to like interrupt her because you're like, I just want to hug you right now because you look so comfortable for the first time in so long. And so she finished we do like a little in-office session to make sure that they're comfortable, no sound sensitivities, and we don't need to make any programming changes. And she finished it and she just looked up and she was like, holy cow. And I was like, yeah. She's like, I'm gonna go sit in the waiting room and just do another one. And it was just one of those, this whole calm came over her body. And she has just done incredible. Now, we did go a little bit longer. She is now at this point down to 1 30-minute session a day rather than 2 30-minute sessions a day. So she's kind of slowly on like a weaning off pattern at this point. But the things that she is continuing is that quiet time, relaxation, meditation, and deep breathing time, and trying to keep kind of that carved out path of I just get quiet me time during the day. But she has been a super responder to it, and this is someone I had longevity with prior to this versus a completely new to my clinic, new to me because of this particular device.
Interesting. Now, to my knowledge, this is how it's designed to be used, right? You go through your 12 and you extended it on case-by-case basis, right?
Yep.
But it's designed to go for 12 weeks. You're doing your, 2 sessions a day, typically over the course of that time, 30 minutes apiece. And the clinical trial data showed that even when they stopped using it after that period of time, that they had a consistent benefit from it, right? So it's not like it just worked while they were using it, it worked long term as well.
And that's the nice of it, is that, in the US, we're certainly too new into it to be able to, from a firsthand experience, tell you where our patients will be. I can say, though, that part of being that phase 1 provider is we will be working on gathering that data, and yes, that comes a little bit later because we need to let the time happen. But I have done some 6-month data already for my earlier fits. Now, we're not quite 6-month post 12-week treatment, but we're getting close to that. And I mean, we have regular touch points with our patients, and in general, they do seem to be having a general steady or holding pattern within this. Some patients, though, are hesitant to stop using it because they've done so well and they enjoy it and they like it from a relaxation and quiet standpoint. And there's no harm in them using it longer. So I'm not opposed to them using it as an appropriate tool in that longevity picture if they're safely and appropriately using it. I don't want them living in it. There's, of course, boundaries that we need to look
life,
at.
Right?
Exactly,
yeah,
because it's correct. Because we certainly don't want it. Exactly, but like with this particular woman, she's using it 30 minutes a day. She uses it right before bed. It gets her into her sleep time. With the guidance of her prescribing physician, she has come off of her sleep medications at night. Her tinnitus is no longer to the place where it's like she'll say, "As I have tinnitus, it doesn't bother me anymore." But using this tool has kept her off of her sleep medication. She uses it right before bed. It's her quiet time. She tells her husband, we're not talking, we're done, phones go away. She just does her quiet time and off to bed she goes. That's a healthy way of continued usage. That's not an inappropriate or a concerning usage of it. And I don't have any concerns with her using it as that type of a tool for the longevity at this
So
point.
it's kind of funny. We always talk about what tools can we have as providers to help treat our patients, and I think that there's something to be said for she views this as a tool that she has in her toolbox that she could break out, given that she goes back into swings the other direction into more of a catastrophic state with her tinnitus. So so it's kind of interesting. You could use it that way too.
Yeah, I would fully expect that there's still going to be good and bad days when they're still through the treatment. So you never throw the tool out of the toolbox away when you're done fixing the engine, right?
Never.
It's always going to be there for you when you're having a bad day, and the conditioned response already is there that when you put it back on, life is good because you've had that positive experience with the treatment all the way through. I have very similar responses with a lot of our patients that they really look forward to that me time. There's no distraction. There's nobody asking anything of them. It's just their time to think about whatever they want or relax and do a puzzle or something of that nature that really calms them. And often in that scenario, we're dealing with patients that have real high anxiety or stress. And if they have a point in their day where they have none of that, it is a pretty positive thing.
Oh, for sure. Can you think of a particular patient that you utilize this on that you're like, I don't know if I could have had a positive treatment outcome if I did not have the Lenire tinnitus treatment device?
I just had a follow-up yesterday, actually, with a patient that her TFI, we don't use the THI in our office, but the Tinnitus Functional Index is a questionnaire we use, and it dropped over 40 points from catastrophic down into the mild range now for her. So she still has it, she's aware of it, but she's accepted it. The word acceptance, when I hear that in an appointment, that's when I know the patient is on the right track, that they probably don't need me anymore. Yeah.
And that's a happy day as a tinnitus provider. On the audiology side, in terms of like amplification, we know that that's a long-term relationship, right? Once you have hearing loss, once you're in amplification, you're going to continue needing that. When we hear those moments, it is a happy day.
Oh, yeah.
It is a really happy day when we know that they're probably not coming back on our schedule again because they're well enough that they don't need us anymore.
They have all the tools in their
And
toolbox.
that is a job well done.
Yeah.
And it doesn't mean that they don't have tinnitus, but like Jason said, they've either accepted it or they're in a place that they are so well equipped to manage those fluctuations because life is stressful and life is hectic and we can't predict that. But our role in their tinnitus care is finished, at least for the most part. And that's actually an incredible thing as a tinnitus provider to know that they don't need another appointment with me because we've done what we were set out to do with those patients.
That's very cool. Now, Jason, you had said something about, you have this tool in your toolbox, and me being a guy, I'm thinking like, well, sometimes you have a buddy who wants to come over and use your tools, right? And I'm thinking like, okay, so knowing that you have this tongue tip stimulator, right, that you put inside your mouth, and on top of that, everybody's tinnitus is different. So like, and we see this with hearing aids.
We do.
We see people who are like, listen, my family member passed away. I've been cramming their custom hearing aid inside of my ear, and I notice a difference. My hearing's better, but it hurts, right? What would your recommendation be for someone who's like, oh, my family member has tinnitus, I'm just going to have them use the Lenire device?
It is customized to the patient. And think of it on the level of any other medical device that's out there. It should not be sent to another person because there's no assumed liability with that either. So if you go and break your foot and need crutches, you technically can't resell those crutches either, right? So you're supposed to make sure that it is programmed for the person, and you're putting something on your tongue and giving
Sometimes
that to somebody
family
else.
members are really close. I don't know.
Sometimes,
I'm not here to judge.
Yeah.
Yeah. So, I mean, in my opinion, I wouldn't share the tongue stimulator.
I'm Team Jason on please don't share the tongue tip stimulator with other people.
But I think that is an important point too, which is like this is fully customized. It's not like you're just going in, oh yeah, you have tinnitus here, use this tinnitus treatment device from Lenire, and then you're going to be good.
Right.
There is a high level of customization that you do with that. Can you kind of help walk through, like, what does that really look like for a patient?
Sure. So there's two programs that we have access to in the U.S. There's Program 1 and then there's a second program. Program 1, which I would say
majority.
most of us use predominantly. That is a blended sound. So there's some background sound, there's like water, ocean style sound. There's tones that go in there, kind of low tones to high, high back to low, kind of beepy sounds. Think of it like spa music. That is a set pattern, but then the frequencies and the intensities of how you as an individual experience that pattern are programmed for you alone, because we use your audiogram. So everyone has that same program, but then you might get different tones at a different level, or the intensity is at a different level, because it's used based on your hearing, your audiogram. And so same in that second program, which there's none of that extra sound, it's just tonal. So you'll hear tones here and then here, kind of bounce around. Everyone hears the same tones, but remember, if you have hearing loss versus normal hearing or not, you're going to need to receive a correction factor to know that we're delivering them at the right level. So with a normal hearing ear, and then if somebody had hearing loss and I were to put those on, I wouldn't want to put on the correction factor of somebody's program that might be programmed with some hearing loss, because I could potentially cause harm to myself. So it's not, so that side of it is fully programmable per the listener, including right ear, left ear. So I mean, it's right side, left side, and you're hearing it, and they don't match each other. So it's not identical, it's not binaural summation in terms of everything is not the same from the right ear to left. Some sounds will start right and you kind of feel them almost blow over to the left. Some go back to this. Sometimes you'll hear higher here, lower. I mean, so it's this constantly moving signal.
It's relaxing.
It is very relaxing. You need a chill out moment, put it on. You're just like, okay, here we go. This is great. And so with that being said, it is programmed. And so there are some safety precautions that you want to be careful with that. And then the calibration is also calibrated to your tongue. And so when we do the calibration to each person's tongue, we provide them different stimulus. We're going for the lightest ability of them to be able to perceive the stimuli. Because when we calibrate it, it's only 4 electrodes are turned on, but then when we turn the whole therapy session on, all 32 are turned on. We don't want this to be spicy. This is not meant to be tingly, metallic-y. This should not hurt. It's different. We are not used to having something like this on our mouth, but no part of this should be uncomfortable. If it is, that can actually have an exacerbation effect on one's tinnitus. And so the goal is not stronger, louder, harder, better. It's actually softer. This is intentional, comfortable. This is meant to be very comfortable, because also think of it this way. If you're nervous about getting started with this because it's so uncomfortable, or it's so loud, or so intense, or too much for you, how are we supposed to ask your brain to allow this information in and to be able to accept this information if you're scared to start the treatment because it's painful or uncomfortable or pushing you over your threshold limits, which is why the audiogram is important, the calibration step is important, and then that listening during your fitting process is important, because if we identify maybe one of those tones is too much for you, great, let's change it. You don't need to have it be at that level. We have the ability to reprogram it so that you're within a safe parameter for yourself. And many of these people do have sound sensitivity levels, so that's a valid thing that we deal with on a regular basis.
I think that the one thing that maybe some people are like, I don't know, like, you're going to put a tongue stimulator on me, and like they're thinking like electrotherapy or something like that. But you're saying that's not what it is.
It's so light.
It's very light. It's kind of like having soda water on your tongue, right? It's not like licking a 9-volt battery like I did when I was a kid, but it's very, very soothing. And to be honest, it's not harmful.
It's
not
very comfortable. Yeah, no part of it is uncomfortable. In fact, that's one of the things that we'll always ask is, was that uncomfortable, is bothersome? If you take it off and your tongue is still feeling that, I want to turn it down. You should not have, the second that comes off, you should not have a lasting impression that it's still happening on your tongue. That means we have it too strong.
So you said that you do an initial when they're in your office to see how they react to it. Jason, you do the same thing, it looks like. So you have them initially do it in the office for their 30-minute session there, and then it becomes more like at your direction, but they're doing it at home for that 12-week time period. I imagine you have check-in points over the course of that 12 weeks, and then you have your outcome assessment. And then what is the typical follow-up on that? Like once they hit acceptance, maybe inside of that 12 weeks, like do you always have a touch base just to check in with them to see how they're doing? Or is it more like if it reaches a point where you feel like you need my help again, they come back in?
So I'm going to answer this pre-linear just because we're not deep enough into long-term linear data in the US to be able to, from a first-hand experience, answer from that. I still like that whenever we're completing treatment, whatever that looks like in the office, and I'm talking specific to just tinnitus specific treatment, I always do a 6-month post-treatment and a 12-month post-treatment. I don't foresee me changing that at all with Lenire. One, we've been asked for those data points, and two, I think it's an important time. But the caveat always is, anytime that you need us, you call, text, or email.
Yep.
Because maybe you are doing really well, but you're just having a hard day. It doesn't mean we have to fully get reintegrated. Maybe you just need one appointment. Let's have it.
Mm-hmm.
Let's not undo all of that excellent work that they've already put the time and energy into. So I don't see me changing that kind of post, looking at the 6-month, the 12-month. If you're doing well, wonderful. But let's still just have a quick touch point. And I always tell them, I'm going to reach out to you. I hope I don't hear from you between now and then, but I'm still going to reach out for you at that time. And if you're open and willing, we'd like to see how you're doing. Just to let them know, like, we're not calling you expecting something to be going poorly. We're calling you to follow up to make sure that you're still stable, you're still doing well, and just looking at it from that longevity standpoint. So I expect that to just continue through, and I don't expect that to shift much with Lenire.
Yeah, I'm almost the same. Yeah, we when we feel like we're at a point where they have the tools, maybe they're not acceptance stage yet, but they know all the things they have to do, we'll switch to 6-month appointments, and then when we do graduate them from treatment, we'll go to 1-year appointments as well, just to check in and do a new hearing evaluation.
Yeah. And who knows, like maybe hearing aids down the road or something
Yeah.
for them if they develop hearing loss. I mean, we're all getting older, Lord willing, every day.
Mm-hmm.
So I do want to talk about, because I think that some people may be watching this and saying like, well, of course you're saying that this is extremely effective and you go through this process, you get Lenire, you're going to have success. Let's just be clear here. Like, even in the clinical trials, not 100% of people had success with Lenire.
Right.
There are people that it does not work for. Either they were not the right candidate for it, or they were a good candidate for it, but it just was not effective. Like you guys, in this validation study that you guys have been a part of, have you seen the Lenire device be not effective for certain people?
Mm-hmm.
Yes.
Yeah, and I would say for me, the big part was that, maybe I was setting expectations in words and they were using pictures in their mind of how that looked, and it didn't match up very well. So the expectation side of things was probably the biggest factor where we haven't seen success. But there are still some that they're still doing the treatment, but maybe not seeing the numbers drop on their questionnaires yet. But we'll give them time. Habituation happens. It's just a matter of when. Yeah.
Well, and sometimes it happens in a different manner than they were hoping for it to happen. And so in some patients we'll find that they have like a literal lessening of their awareness of their tinnitus. So they'll have like a quiet day, and then quiet day 1 goes to quiet day 2, sometimes to quiet day 3, but then day 4 is loud, right? And that can be alarming and frustrating for them. And so they'll kind of, they'll come back into their appointments and they're like, I had this many quiet days to this many loud days. And so you have to kind of rework that parameter. Then on this other side, you kind of have their scores start to drop and they are less bothered by it, but they'll still tell you, well, I hear it just as often as I heard it before. It's still there. I'm aware that it's there, but it doesn't bother him anymore. It's not as intrusive for me anymore. And it's not that. So you kind of have this like category A and B. Neither of them are better than the other. Neither of them are a more favorable outcome than the other, but they are both significant in reaching towards that stage, but they're different versions of what does success look like. And so I've got some of these people who are so happy they have X quiet days, but then on their hard days, it can be really hard because their brain hasn't accepted it as nicely as this kind of category of patient, because on their loud days, they're like, ugh, here it is again. And they just perseverate on that. And that can be a really hard thing to focus on. Whereas you have this group of people, they're like, well, yeah, I still hear it all the time. But you know what? It actually doesn't really bother me that much anymore. But if I asked them, do you hear tinnitus? They're going to say, yeah, it never goes away. It's always right there. But because their brain has learned that redirection, it's no longer the forefront. They tend to have, in general, less fluctuations with their tinnitus days because their brain has taken a hold of that process and they're not as intrusive of it or as alarming of it. Both of these can be successful outcomes, but they're different. and I can't control which direction their brain takes those outcomes. And I have yet to figure out, how do I know if your brain's going over here or heading over here? But they both have very good, valid measures of how they're both successful in different outcomes. And sometimes you end up with a B and they really wish they were an A, or they're an A and they really wish they were a B. And I haven't figured out the way that we make the brain do the opposite. And so that can be hard too, is managing that expectation of, like, clinically, look at how far you've come. But all they wanted was that version of an outcome, even though they had so many other rubrics of wonderful success in their mind. It wasn't the only acceptable version of an outcome, even though technically, clinically, they've done successful, not to them. And so sometimes you have to really line up, what does their version of success mean, and how do we manage that from the beginning? Because sometimes we need to almost remanage what success looks like before we've started, because they might miss how successful they've actually been because they're so closeted on what they see as the word success.
And that really, it requires someone who is an expert in tinnitus treatment to kind of realize this stuff. Because if you take someone who's a novice in it, or someone who is a hearing aid fitter who dabbles in, like, oh, your tinnitus went down, right? Those are not typically the type of individuals who'll be able to key in on that aspect of the tinnitus treatment and whether or not someone has actually had success using a product, right?
Oh, yeah.
Well, and it can be detrimental for that patient if you don't validate their experience and recognize their experience, because it is valid. They're allowed to be frustrated that they didn't get the directed outcome that they were hoping for. So we can both mourn that side of it and then also learn, how do we celebrate this other side of it? Whereas if you're not experienced in working with those patients, or how to identify that, you can derail all of the progress that they had and potentially backtrack the success that they were having by not validating. If you look and you're like, well, you went down on score. Okay, but they don't see that. They don't recognize that. They're in distress right now. They don't care what their number says, to be fair. And that shouldn't be the focus of your conversation. It's a tool also, but tools don't trump what their experience and their feelings and their behavior is in that moment. And so, like, how do you incorporate that in? And so that's where the knowledge really comes into play, because they potentially are in a really precarious position that we could turn this around and help them see how well they've done, or we could derail them and send them, unfortunately, down a poor pathway because we misdirected our ability to guide them in the correct pathway.
Yeah. You would touch base also on something, like, we're really dealing with the human brain here, right? It's not just the ears. In fact, one of the things that I saw, that the reason we believe that the Lenire tinnitus treatment device has been so effective is that you have this aspect of the bimodal, right? So not only are you doing sound therapy, you're doing tongue stimulation as well, and I believe that it's the compounding effect of that rewires the brain. Am I saying this the right way with what that actually does?
I think that the tongue stimulation using that trigeminal nerve is reinforcing that the sounds coming through the headphones are more important. So that way, when you are hearing the tinnitus and those sounds at the same time, your brain starts to focus on those sounds and says, this is not important anymore. That's the process. The tinnitus is not going away. That's not our job. It's not our goal, I should say. Our goal is to make it so you don't perceive it on a regular basis or affecting your quality of life in that scenario. So again, redirecting the expectation of the patient. If they come in with tunnel vision that I'm going to put this on and my tinnitus is going to go away, it's not going to happen. That's going to cause a lot of frustration. So working through that with them and really aligning on what the expectations are is going to be the biggest challenge with those patients.
Do you think it's more effective because they are using the tongue as the stimulation point rather than something else?
Well, I think that's part of the theory, on top of the fact that it might be that the effectiveness long term is also there. So after their 1 year after they did the study, that the patients were still seeing the same benefit, I think that has a lot to do with it.
I kind of have a two-part question for you guys. So the first part of it is that when we started the show today, we were talking about there's been other tinnitus treatment things that are out there, products that could be used that really either they're not used widely or they just don't even exist anymore at this point. Do you think that the Lenire tinnitus treatment device falls into that category after having collected 6 months of data inside of your clinics?
Well, I think that, goes back to the whole responsible thing that I talked about earlier, is I think that they are trying to be a long-lasting treatment protocol and product, not just a fly-by-night situation. And so I think that they can stick around a long time and can be a very effective product. I try to use evidence-based treatment protocols in my office. There are a lot of tinnitus treatments out there that are not, and patients will try them. I just try to educate on, here's what I would expect. And if it doesn't go well, the likelihood of it harming them may not be very high. So come back and we'll talk more about the real treatments if necessary. Yeah.
Yeah, and I agree. And they did put a lot of time and energy and strong science data into this, which I think is a favorable position. Some of the other companies that have come and gone either had fairly rudimentary or kind of preliminary information, but didn't necessarily go quite to the extent that this went. And there have been other data that was excellent, and it just didn't quite work. I think one of the things that has been, I know, on a frustrating side for audiologists not with access to the device is, but I have patients and I want it. Part of keeping this and hopefully getting to keep this as a long-term solution for these patients, because like we've both talked about, we're finding them to be favorable results, is not putting it in the wrong hands. Because as soon as it goes into the wrong hands, and you're going to watch outcomes fall, and the lower the outcomes, the higher the fail rates, and the statistics are not going to be in their favor. That's no different than if someone that's never done a cochlear implant map turns on a map and just pushes a bunch of buttons and doesn't know how to run NRTs and what to turn on, and then they're like, what do you mean you never learned how to be able to understand that again? So, when providers are looking at this, or when we're looking at it from there, not everything is meant to be hands-on by everybody, because we all are not able to do everything at an excellent level or at the level of that. And that's where there's many things in my practice I don't do at all because I'm not an expert in them. And so then I refer them out to my colleagues. And so, kind of protecting this, and right now protecting this so that way when these patients really need these types of devices, hopefully they are here for a long time and in the future to come. I think, coming from that perspective, is the company Neuromod is just as protective of that, because they don't want to be another company that kind of came in, flooded the market, and then disappeared.
Yeah.
And so, that's part of our role in there as audiologists, of whom are just audiologists that asked to get participant in this, is it's been working really well, and I personally would like to have access to this tool for a long time into my career. And so, keeping the integrity of it is important too.
Yeah, I think it's like a scalpel. You don't just hand a scalpel to anybody and be like, go perform that surgery. You have a very good scalpel, right?
Yeah,
right.
Like, you can't do that.
Right. I think that they've also been redefining how they teach us as providers the information about Lenire as well. And trying to make sure that the people who do get it have to go through that protocol before they start getting it. And they've worked through several layers of that since we started, even in Dublin.
I mean, we've learned things that have shifted since we were all over in Dublin, and there's new things from the data that we've all turned in. We're starting to potentially see, this might be an outlier of a potential reason we would not move forward with a patient, that we just didn't have the data prior. And from all of us collecting, we're now working on that data pool. So, I mean, it's a company that is very interactive, and they hear us. We do a roundtable call every month where we can bring case studies, we can share, we can say, guys, I need help with this one. What are your thoughts? Work through. We can all call and text each other and say, hey, are you able to walk me through? I've got a difficult case. Let's all talk about it. Mm-hmm. And so, when we're looking at it from that perspective, this is a company that's been very open to hearing us, and then hearing that data information, and then coming back and saying, how do we work on this for the moving forward part of that? And I think that's important, because when we've identified a potential concern, they don't just brush it under or ignore it. No, it's immediately then implemented when appropriate for the moving forward for those new phase providers coming in, so that way they can learn off of the information that we learned trial by error. Now they already have it, and they don't have to learn trial by error. Right. They can have that data that we've already extrapolated from being kind of thrown into the gauntlet, so to say.
Yeah. I'm the master of implementing processes and procedures that other people have deemed to be the best practice, right? So so I totally understand that aspect of it, and I love that you guys are willing to figure all that stuff out and take the arrows, from that learning process for the rest of us who will hopefully at some point be able to start incorporating the Lenire tinnitus treatment device into tinnitus treatments that we start inside of our clinic. So I guess the second part of my question after that is, do you think that you could go back to a time without having that device inside of your clinic? Now, I know you could, so I guess I should rephrase that. Like, I know that you, like, if Lenire went away, you would go back and you would continue to do tinnitus treatment at a high level inside of your clinics. The question is, would you want to?
I don't think so. And I think because, as we pointed out before, it is an alternative to just amplification, because sometimes amplification is used. Sometimes they're too turned off, whether it be from a poor experience, out of fear, we're not ready for hearing aids, whatever it is. Sometimes it's nice that we have an alternative entry. And I think it's nice that we've got an outside of the box different approach, because this really addresses the ear to the mind and brain connection rather than just one side of that pathway. And so I think it would be hard, not that we couldn't, we've been doing it for years prior to this successfully, but I think it would be hard because this tool has shown to be effective. But I also think that this is only the beginning of bimodal neuromodulation for all of healthcare. There's a lot of bimodal neuromodulation devices that are getting ready to come out, not just in tinnitus, but in other areas of healthcare. And so I think this is the beginning of things to come when we're looking at healthcare. And so I would say, as providers, for all of us, regardless of our areas, of being open to kind of that outside of the box thinking. And it's not necessarily the process that we learned in school, but look at that information of what we learned in school about the brain, about the ear, how those connections work, and putting those pieces together, and then being willing to listen to the people that have focused their time. And that applies to kind of all of our areas. So I think it would be hard to take a device that I have been finding great success for the vast majority of our patients that have used it are doing well with it. It would be hard. It's easy to remove a tool that's not working well, right? Mm-hmm. Everyone's like, good riddance, bye, not doing that again. We're all like, hallelujah. But it would be really hard to remove a tool that so many patients have found easy to use. They're not as resistant to using it because it is comfortable. We're telling them to sit, relax. It's not burdensome to their day or their life. And it has a lot of flexibility in that it doesn't have to be at 10 and 6. It can be here and there, and you can fluctuate from within there. And sometimes that's nice because life is not always very participatory in our schedules, and so having the flexibility of using it is also nice. And I think that would make it hard to take that portion of the tool away. However, though, we'd learn to pivot and we'd figure it out, but it would be hard to remove that one at this point, I think.
I definitely would not want to go back before Lenire, for the fact that I've also got a chance to have a seat at the table of designing how treatment going forward should be for clinicians all over the country. And on top of that, redefining my own skills on what other providers have used in the study to be more effective as a clinician. So no, I wouldn't go back.
Yeah, I know, Jason and I speak at different conferences across the country, and even looking into next year's schedule of what my talks are already looking like, and it would be hard. This has changed a lot for that first group of us providers. There's been a lot of clinical change that's come, and also the collaboration. It's been an incredible year of being able to collaborate with the same level of provider in the tinnitus field when there's not a lot of us. Mm-hmm. And there's certainly more than just the 15 of us that were selected. By no means are we saying that there are not. I can think of many of them by name that I would have loved to have been in that initial group with us. But to have that extreme openness and willing to collaborate with other providers and walk through that process, which is not always the way of private practice and the way of audiology. Right. It has been an incredible year, and like Jason said, to introspective review of like, what am I doing, how do we need to adjust this, what processes can I do better, how can I grow as this side of it, but then also how are we influencing those that are going to come after us and come into these positions to help them set up those patients for success. Like it's been a really cool year.
Yeah, and they're growing. So like even if you can't make it into one of the clinics, which an interesting aspect is that to some degree some of this stuff can be done remotely.
Yep.
right? Like you can have these initial evaluations and get initially set up, and then do some telehealth along with it.
Right.
But there's also going to be more providers joining on board, very selective again, going through phase 2 and phase 3 of onboarding new providers across the country. Will be opportunities for individuals who think that this might be the option, and even if it's not the option, if you end up going into a clinic that has Lenire, you know that that clinic is a tinnitus clinic.
Yep.
Right? You know that they have a higher level understanding of the treatment process of tinnitus that you will not get from a standard clinic that primarily just uses hearing aids to treat the tinnitus, right?
Correct. Yep.
So guys, thank you so much for joining me today. You literally flew down from Alaska and from Minnesota to do this show. So I greatly appreciate that. As a token of my appreciation, I like to get little gifts for everybody who comes on to the Dr. Cliff show. So I'll have you guys pop those guys open right there. And you guys forever will remember your trip to Arizona to be on the show.
Thank
And there you go. You've got your own Dr. Cliff mug there.
Thank you very much. Yeah.
Cheers.
Yep, cheers guys, and much appreciated guys. If you enjoyed today's episode, make sure that you hit that like button, and if you're not yet subscribed to the channel with notifications turned on, go ahead and do that as well, and we will see you next time.